Right. Welcome, everybody. Today is Thursday, January 30th, 2025, and this is the VCU Department of Internal Medicine Grand Rounds. Just as a reminder, we are here in the Molecular Medicine Research Building. Today we are in room 1013, and CE credits are here on the screen, and New Innovation QR code is available for the residents. So we have two back-to-back Division of Nephrology lectures this week and next week. To get us started, for today, Dr. Gupta is going to introduce our speaker, Dr. Parikh, who is from Johns Hopkins University up in Baltimore. Please help me in welcoming Dr. Gupta to come up here and introduce Dr. Parikh.
Well, good afternoon, everybody, and thank you for those who are attending in person here. So it's an honor to introduce Dr. Chirag Parikh from Johns Hopkins. He's the director of the division there, as well as the director of the Precision Medicine Center of Excellence. He's also a professor of medicine. So he is originally from India, like myself, but he did his fellowship at the University of Colorado under the mentorship of Dr. Bob Shire, who's a giant in the field of nephrology. In addition, while there, he completed his PhD in clinical investigation. He has been awarded several NIH grants, published over 500 original articles, cited over 50,000 times in the literature. His research focuses on the translation and validation of novel biomarkers for the diagnosis and prognosis of acute kidney injury. I'm personally privy to his work. It's excellent, high quality, including a very recent paper in JAMA in the last few months. Today, he's going to be talking to us about phenotyping of AKI, precision medicine to clinical trials. So welcome, Dr. Parikh.
Thank you, Gaurav, and delighted to be here, honored to present the medical grand rounds, and looking forward to meeting several faculty. So let me see. Okay, so what I'm going to cover in the next 40 to 45 minutes is phenotyping of AKI and how we are making tremendous progress in the field, starting with making subgroups of AKI with using precision medicine tools and then doing smart clinical trials in this heterogeneous disorder. This is my disclosure. Majority is NIH grants in this area, along with some scientific advisory boards who are doing clinical trials in the space. So for the first third of my talk, I'll go through phenotyping in the post-discharge AKI. And I'll come very quickly why in that space. Then ASSESS-AKI study, which is a large NIH multi-center study that helped us understand what happens here to patients after they go home. And then these are ongoing recent studies which look at AKI to CKD transition. And I'll give you snippets on each of them. But essentially, this is our underlying problem. AKI is an acute illness that affects tissues, affects many different tissues and induces acute kidney injury. Essentially, when a patient is admitted to the hospital, they go through several physiologic stresses, inflammatory stresses. You can be on the medical ward and get nephrotoxic medications or any medications. You can have infections, you can have ischemia. You can be on the surgical ward, receive a cardiopulmonary bypass where a surgeon put you through 2 hours of cardiac surgery. But we see that despite having similar insults on many people, so like 100 patients going through cardiac surgery, about 10 to 15 of them, they end up with acute kidney injury. And we think that there are certain people who could be predisposed to these physiologic stressors or to the inflammation that comes with the stimuli that pushes them towards development of acute kidney injury. And as our population is getting older, as we do second cardiac surgeries and we keep our 70, 80-year-olds alive through pneumonias and COVID infections, we see that the incidence of AKI is increasing both in the hospital as well in the ICU. Essentially, a third of the patients in the ICU are consulted by nephrology. But what is the developing paradigm of acute kidney injury? Although it is a heterogeneous disorder, we are seeing that after the patient is discharged from the ICU or from the hospital, the disease is not over. Although the serum creatinine may come back down to normal, it is a meta-stable condition. And what I mean is stable state is not a steady state. The creatinine is down to normal, but there are a lot of physiologic changes, biologic changes that are still ongoing, where the recovery takes another 3 to 6 months. So the subset of patients who had AKI will end up developing chronic kidney disease, will end up undergoing maladaptive repair and not come back to the healthy state. So you may start off with several 100,000 nephrons, you got a state of AKI, you may be left with fewer nephrons because you went through a maladaptive repair. Your creatinine may not change, but you have predisposed yourself towards getting a CKD. And that's the AKI to CKD transition that we are seeing. And this is across all the medical and surgical conditions. The common factor is there are a subset of people who will get CKD progression. And this is kind of the punchline that comes across the literature that AKI probably is one of the strongest risk factor for progression of CKD, and now more than diabetes and hypertension. People who get AKI have 3 to 7-fold higher risk of developing CKD, and they also have higher risk of rehospitalization, premature mortality, and cardiac events. So you may be encountered with a patient like this, and this is one of my patients. He's a 70-year-old diabetic engineer who had elective CABG surgery, and his creatinine before surgery was 1.5, so mild CKD. He developed low blood pressure during surgery intraoperatively. By day 2, his creatinine had almost doubled. So this is stage 1 AKI. By day 5, he developed acute dialysis. And after a few days of dialysis and observing him, he was discharged at creatinine of 1.6, almost back to baseline. And he comes to the clinic for a 3-month follow-up visit. And he's a very sharp guy. And he's asking me, am I at a higher risk for progressive kidney disease and future hospitalization? Should I follow up with a nephrologist for the rest of my life as part of medical care because I had an episode of AKI? And are there interventions that I can do so that my kidneys remain healthy and they don't get CKD? And these questions are emerging more and more among patients as they are scouring the web and looking up the literature. But it begs the question, like last week I was on consult service, saw over 50 new patients, but they had all these different conditions. There was an old man, a 77-year-old man who had lymphoma, who was started on chemotherapy and had developed tumor lysis syndrome. There was a young woman with pancreatitis. There was a patient with a staphylococcus bacteremia and endocarditis. And you can see the heterogeneity of AKI, and we have to pass through this to see whether all of these patients would have similar prognosis or which of these patients would be at a higher risk for AKI to CKD transition. So once again, the emerging theme is a patient developed AKI, creatinine came back down to normal, which happens in 90% of the people. Some 10% people will get partial recovery, you know that they are the highest risk. But among the people who get a reversible AKI, some of them will have a maladaptive repair. So if you're thinking in terms of biology, will your epithelium heal as epithelium? Will your tubular cells come back as the epithelium with all the fine channels and all the fun work that the kidney does, or will it be left with a scar like we see on the skin? Will you be left with a keloid? And here, the literature or the work is going towards identifying the risk prediction models or biomarkers where we can identify people with maladaptive repair. And once again, these are the Achilles heel of the field, creatinine-based methods. They do not capture the sensitivity of the injury that we want because it relies on muscle mass. It is an indirect measure, and it can be affected by a lot of different things. And we need biomarkers or better proteins to detect ongoing inflammation or subclinical injury, things that are worsening while the creatinine is normal, to predict long-term clinical outcomes. And this is the different trajectories based on the type of repair. People will get AKI to CKD, a small fraction will get full recovery. But we are seeing many patients who get progression of CKD and within 1 to 2 years after AKI end up with ESRD. And for medical students or residents who are listening, the AKI definition is not very sensitive and it's largely imprecise. It's more of a screening definition. It tells you that if the creatinine has increased by 50% or by 0.3, the kidneys are affected. It doesn't tell you what the etiology is. It doesn't tell you what the prognosis is. And but it brings it to your attention. And you can see this is the current staging, highly imprecise, highly dissatisfying. And so where we have done the work and where others are moving is understanding the structural damage that is happening to the kidney. Can we quantify the structural damage? So when we think about AKI, it's a disease of the tubule. Creatinine is a marker of filtration. And generally speaking, in a setting of AKI, the glomerulus is fine. So if you're using a measure that is a marker of glomerular filtration to assess the tubules, you're not going to be very precise. You're going to be fairly off and misclassify patients if you're trying to think about their prognosis. So when I think about AKI, the picture I get in my mind is forget the glomerulus, how are the tubules? What is the health of the tubules? Are the tubules apoptotic? Are they necrotic? Is there inflammation around the tubules? And all of these conditions will decide whether you will recover fully from your episode. So
Sorry about that. Can I hear from someone online? Can you guys hear me now? All good. Okay. Okay. Sorry.
I'm not going to go back, right? No. I'm just teasing. So this is the nephron, and this is how we can track it. And there are also pathophysiological processes which happen in the kidney, which are very unique to the kidney. The interstitial inflammation is a unique process, and there are biomarkers that track it. The endothelial damage is also unique, and these got FDA approved, the TNF, R1, R2 for early diabetic kidney disease. The repair, YKL-40 is a very good marker that tells you about the repair of the kidney. So how can we leverage all this information? And the newer definitions of AKI are trying to bring in the structural and the functional assessment into the kidney disease, where you have two axes in terms of thinking about kidney health and repair. This is the functional axis where creatinine is normal or creatinine is elevated. And here the tubular state or the injury is absent or the injury is present. And if you think about this in this 2x2 fashion, you end up with your original buckets of assessment of kidney injury. The cases where the injury is absent and the creatinine is elevated is your pre-renal AKI that is there in the medical textbook, or we call it hemodynamic AKI. The cases where the tubular injury is present as well as the creatinine is elevated, these are the cases when you go into the urine microscopy, you see the ATN cast, you know that the tubules are affected. This is your classic state of acute tubular necrosis. And another bucket that we are really missing is the subclinical AKI. There are a lot of people where there is ongoing injury, but the creatinine is normal. It's the similar state where troponin is elevated, but the echocardiogram is normal. Unless we identify these people, the epidemic of CKD will continue. So how can these things help? So in the setting of subclinical injury, we want to identify this group because we want to preserve their renal reserve. If you have people who are chewing up their nephrons on a daily basis from whatever insult, you want to identify this, you need the biomarkers. Or these become very good endpoints for intermediate outcomes for AKI trial. You can have a new drug where the creatinine may not change, but you may see that certain markers of tubular health are getting better. That drug should go forward in terms of drug development. The group which is left and bottom, which is the prerenal AKI, is super important. We miss this quite a bit. And these are the people who have hemodynamic AKI or prerenal azotemia. And we need to be thoughtful about these people or these conditions in the setting of CKD trials. So if you look at SPRINT trial, the overall outcomes are positive, but when you lower the blood pressure, some people end up getting AKI. Or when you start ACE inhibitors, the overall outcomes are positive. Patients live longer, cardiac events are less, CKD progression is less, but some people get AKI. Same thing happens with SGLT2. We have shown this in the setting of cardiorenal state and in contrast, where the bump in creatinine is not affected with injury. I call this group as permissive hypercreatinemia. If you are going to take one thing home from the talk, this is the group where you have to leave it alone. Don't stop the ACE inhibitor, don't stop the SGLT2, continue your life-saving strategies. This rise in creatinine is benign, not associated with injury. This is acute kidney success and good outcomes. But unless you are thinking about it, unless you are measuring something, the inclination would be, oh, patient is getting worse. Let me stop the diuretics on a cardiorenal patient and see what happens. This is the place where nephrologists are needed, the intrinsic kidney injury. These are the cases of real ATN. Here, our goal is to identify which patients have injury, which patients have inflammation. If you think about the biopsy, people who have inflammation, I want to give them steroids, I want to give them Cellcept. And this is the group which is more AIN compared to ATN. In ATN, we want to help with the recovery of the tubules. We want to bring dialysis maybe slightly earlier and see that they recover well. In terms of research, this is the group where we want medications which will take the patients towards adaptive repair, and this way they will get a complete recovery of their epithelium. But if you think about AKI in this way, you will parse out the patient so that the heterogeneous syndrome will get the right management till we have all these biomarkers available. So coming to the setting of post-discharge AKI, and this is where a lot of focus is from the NIH, from the industry. And we are trying to see, are there biomarkers of inflammation and repair that can be measured after hospitalization to assess long-term renal function? What is the molecular basis of these biomarkers? And can these biomarkers have applications to inform clinical decisions? So first, we started off with a large observational cohort study, went to the bench to identify the key biomarkers, and now we are bringing them back into clinical trials. So the best contribution for this question is the ASSESS-AKI study. This was the NIH-sponsored study. 4 academic centers. We enrolled patients for over 3 years. The fun part of the design was we enrolled everybody with AKI, but we found propensity matched or matched controls during the same hospitalization who did not get AKI. So you cannot randomize somebody to get AKI, but this is the next closest we can do. So if a 70-year-old who came with pneumonia got AKI, we ended up finding a similar elderly patient who had pneumonia but did not get AKI. So the closest you will get to come in terms of control group. We called these people back after discharge at 3 months and every year collected blood and urine samples and ended up studying the propensity for kidney disease progression. And we defined this as ESRD and progressive CKD with a large change in GFR and mortality. But these are the key outcomes from the ASSESS-AKI study. So if you take patients with AKI and match them to appropriate controls and ask your question, what is the risk of chronic kidney disease incidence? New CKD, a patient with AKI has about a 4-fold increased incidence of CKD compared to the counterpart controls who did not get AKI during hospitalization. So if the diabetic engineer was coming to me and asking me the question, am I at risk for CKD if you didn't have it? I would say, yes, you are at a 4-fold higher risk of developing CKD during the 3-year follow-up. People who had CKD, they progressed at a 2-fold higher rate compared to patients who did not have AKI. This is the contribution of AKI. And in terms of heart failure, we saw like an interaction with pre-existing CKD and AKI such that patients with AKI and CKD had a 1.7 higher incidence for new heart failure. And so the question is, we know this is happening. This was in multi-center study, highly generalizable. How do we identify these people who are at risk for these outcomes? And this goes into the translational space where our goal was to bring new diagnostics, new markers, new risk prediction models that would pick up AKI to CKD progression. And we looked at several candidate proteins, but these are the 3 that turned out to be the best. And these are inflammation biomarkers, YKL-40, which is chitinase-like protein. It was first discovered in the lung conditions, but also works well in the kidney setting, MCP1, and the repair biomarker, which is specific to the kidney, uromodulin. This is the one that comes from thick ascending limb of Henle. This is the one that causes hyaline casts in the kidney. It's a very good marker of innate immunity and repair from injury. So to identify this protein, we had to go back to the mice models where we can control the amount of injury and repair that happens. And this is a very unique model for mouse studying atrophy and repair at the same time. So if you take mice and do ischemia on one side and leave the kidney intact, the kidney that got ischemia will undergo atrophy. But on the other hand, if you do the ischemia and remove the contralateral healthy kidney, the ischemic kidney will learn that it is alone and it will repair back to its original state. So if you do these paired models with the same amount of ischemia, which is the unilateral clamp, you can get an atrophy and a repair model at the same time. And then you can compare the genes and the mRNAs across both kidneys and see which are the targets for health and repair. And after interrogating several fibrosis-related genes and repair genes, we saw that CCL2, which is MCP1, chitinase-3-like protein, which is YKL-40, were higher in the setting of progressive kidney fibrosis, and UMOD were higher in the setting of repair. These are all correlations with the fibrosis genes and other known genes in mice. And then we also ended up finding the cells which are producing this. So this is the single cell data in mice. And we see that UMOD is coming from thick ascending limb and distal tubular cells, and YKL-40 is coming from the neutrophils, and CCL2 is coming from, the MCP1 is coming from macrophages. So we had these answers. We said, let us see if we can find these proteins in humans. And the first interrogation that we had was the first post-discharge visit, which was at 3 months after discharge. We had collected blood and urine samples. And we said, do these 3 proteins predict long-term CKD progression? And yeah. And so this was the primary exposure. This was the outcomes. These survivors were followed for 4.5 years. So this is the one slide summarizing the data. So biomarkers at 3 months after hospitalization. This is after the creatinine has come back to normal. They are coming back for a follow-up visit. And you are asking the question, can we predict what will happen at 4 years? If you look at MCP1, for example, and you take quartiles of data, we see that the patients with highest levels will end up getting more CKD progression. Same thing with YKL-40. And you see that for each doubling, the risk was 30% higher for MCP1 and 50% higher for YKL-40. On the other hand, UMOD, which was a marker of repair and health, the results are opposite. The patients with highest levels have least amount of progression. And for each quartile better levels of UMOD, you have a 15% lower risk of CKD progression. So now, even if your creatinine is down to normal, you can assess the structural injury, inflammation, and repair that is happening subclinically and predict this outcome. So if you're trying to build a post-discharge AKI clinic, you cannot call all the 1,000 people that were discharged from the hospital. You can pick out a subset of people on whom the risk is the highest. And how do you bring back to clinical trials? So we did a very simple score here. You can give the scores of 0 to 3 for each of the quartiles. And then just a simple way, if you are trying to do a trial in the setting of AKI to CKD, if you want to start a drug at the post-discharge clinic and say you want to start SGLT2 inhibitor because it will end up causing delayed CKD progression, if you don't enrich your patients, the event in the control group is 11.6%. And for a 20% reduction for a drug, you'll need a sample size of 8,000. But if you're able to enrich by doing these biomarkers that we are proposing in some trials, you can enrich your event rate threefold. Your required sample size is 2,000, 2,500, and you can get the trial done in a much smarter way. So these are different ways where assessing injury and biomarkers can help you with therapeutic enhancement. So going to the last part of the talk, which is other ongoing clinical studies in AKI to CKD transition, these questions are germane in setting of kidney transplant. This is the Kidney Precision Medicine Project, which is more mechanistic and giving out more candidates for drug development. And this is a clinical trial that is in the post-AKI space. So I'll run through the scenarios. So the clinical question in the setting of deceased donor transplant, which I know Gaurav is also working on and few other people are, we want to expand the pool of deceased donors that are available for transplant. However, if the deceased donor has AKI and the terminal serum creatinine before transplantation is high, the score, the KDPI score, which the surgeons use at the middle of the night to accept the kidney, gets increased if your terminal creatinine is high. And for a same patient who's a 59-year-old male, weighs 70 kgs, who died of a CVA, if his creatinine went from 0.6 to 1.6, the KDPI score becomes 71 from 51. Suddenly, everybody gets nervous, and the kidney has a very high risk of discard or non-utilization. And we have measured this, and in the literature we have published, essentially, a AKI kidney has a threefold higher risk of discard, and over 1,000 kidneys are discarded every year just because of AKI. The total discard is much higher, but this is the AKI-associated discard. So the novel paradigm we were asking is the deceased donor is in the ICU for 3 to 4 days. The acute injury is over. Some kidneys may already be in the repair state. This is the natural history of AKI. There's an initiation phase where creatinine goes up. There's extension phase where surrounding tubules are affected. Then the kidney goes through dedifferentiation and repair, and then there is recovery. We catch the deceased donors somewhere in this area because it is 3 to 4 days before the OPO comes in, the family comes in. Can we measure these adaptive proteins and say that these kidneys will have chance of successful repair? So we worked with few OPOs and collected samples, again, a multi-center study, just before they were getting nephrectomy, and studied the same proteins that we saw in the ASSESS-AKI setting. And I won't show you the primary data in the interest of time, but UMOD, YKL-40 both did extremely well. Instead of MCP1, osteopontin was a better marker in the setting of deceased donors. And we have papers about this. But these markers, if they are present in the urine at the time from deceased donor, the kidneys do very well in the recipient. These markers are markers that the kidney knows how to repair. So even if they get DGF, presence of YKL-40 ensures that the long-term graft failure is not present. And so we were quite happy that in two different settings, transplant and non-transplant, we end up seeing these findings. When we went back to the OPOs, they said, oh, we cannot do ELISAs at night, we cannot do immunoassays, we need something simple. So we ended up developing lateral flow devices like the COVID test that the OPOs can do at the time of harvest or nephrectomy. This is how it works. All the staff at the OPO are trained, the OPOs that are working with us, minimal training. The urine is put in with a diluent, and you get a pink line, and you get the control line as well as the test line, and you get a quantified result, which goes back to the cloud, and we can recalculate the KDPI score to give you the new score that will tell you the risk of the failure in the recipient. So this is our vision. This is an ongoing study. We are thinking that along with the KDPI score, it's going through some changes, but we need some biological variables about the kidney. So if we get a urine sample, the OPOs run this, we can have a new test. And by the time the kidney is allocated, the surgeons at the recipient site will have a better time in terms of accepting the kidney. So as of last quarter, we get updates every quarter. 735 unique donors have been enrolled from 2 OPOs. Our goal is close to 1,000. These are the 2 OPOs who are participating. And we'll get to see the performance of the biomarkers along with these LFDs with the KDPI score to see how much is the new classification helping with the kidney discard. The second piece in the AKI to CKD is the Kidney Precision Medicine Project. This is probably the benchmark project that is going to drive the field forward for many, many years. It's been funded for 7 years now. We are one of the sites, but essentially, we are emulating what happened in oncology. We are taking research biopsies in patients with AKI and CKD, not the clinical biopsies, research biopsies. Patients are signing up to this, but the goal is once the research biopsy is available, these biopsies undergo the state-of-the-art technologies, the spatial metabolomics, spatial proteomics, the single cell RNAs, single nuke RNAs. All this data gets put into the bioinformatics servers to identify new pathways, new subgroups, so that we can have individualized therapies for different patients. So the way in oncology, breast cancer is now made up of 50 different subtypes. AKI and CKD will have their own predominant pathways that could be interrogated. So this was the first publication, which was the Kidney Atlas. The version 2 is being written right now. But here it was very interesting to see that we found 32 different cell types of the kidney. We found different cell states. These are patients who have CKD, who are outpatient, and you end up doing the biopsies. You see that even though the creatinine is stable, we see all these different cell states in a patient with CKD. Some are in the maladaptive state, some are in the degenerative state. So this there is a dynamic process going on. We learn about the neighborhood that these cells are talking about, and they were linked to the clinical outcomes. Lots of information in this paper, but the most wonderful resource is the atlas.kpmp.org. You should write it down, people on the web. You can put your favorite protein in, pictures will come up, pathways will come up. It will give you all the cool stuff you need for your PhDs, for your papers. All we ask is just give credit to KPMP, but you can download all the data sets you want. And as soon as the interrogation is done, we put it up in the web so that it's available. So huge resource for bringing PhDs and everybody else in the field. And this is a use case of AKI. So I'm part of it. I had a fellow who did a PhD, and as part of the PhD, we said we'll use the KPMP data. A very simple question. We did biopsies at the time of AKI. We wanted to see what is the difference between an AKI patient who was injured and had a successful repair versus AKI patient who was injured and had a maladaptive repair. And all this data can be downloaded from KPMP, so you don't have to do much. But these are COVID biopsies, which are non-COVID. 13 biopsies, half of them were done at our center. These are COVID biopsies. These are healthy reference. But you can see that a proximal tubule, based on the different transcripts, the mRNAs that are present at the time of the biopsy, you can divide them into 6 different subtypes of proximal tubular state. And then these are the non-healthy states. The S1, S2, this is the healthy state. This is a non-healthy state. But you can see that as a concept, you can take the transcripts that are present in the non-healthy state, link it with the plasma proteome, the samples that you have collected at the same time, identify biomarkers, the non-invasive biomarkers which are present in the plasma, and link it to the complications after AKI. You don't have to get up from your computer to do this whole study. And this was published in Science Translational Medicine. I'm exaggerating, but all the data is available. So the concept here is in patients with AKI, we get this new, if you do the UMAP plot, we get this new transcript, which is the maladaptive state. And these have around 1,000 differentially expressed mRNAs. These are the molecular talks that are happening while the kidney is undergoing injury and repair. We had proteomics done in our cardiac surgery cohort. These are not the samples from the same cohort. This was very early in the KPMP lifeline of doing this research. But when you combine the two using simple bioinformatic techniques, we end up identifying 3 proteins that tell you that the kidney will undergo maladaptive repair at the time of AKI. We found 3 proteins that will tell you that the kidney will undergo full repair, healthy repair at the time of AKI. And then the other 2 were kind of good, but when we did multivariate adjustments, they did not stand the test of independence. But essentially, we found 6 proteins that can tell you what will happen to the patient at the time of AKI when you did the biopsy. So exciting times in nephrology, but essentially, if you can integrate transcriptome and proteomic features, we can identify novel markers of tubular health and repair. And repair in the proximal tubule has a homogeneous response across heterogeneous AKI etiologies. I forgot to mention that the 13 biopsies that went through, each of them were different. People had nephrotoxic AKI, there were cases of rhabdo, there were cases of sepsis, there were cases of simple ischemia, but so fully heterogeneous. We never thought that we would find such a homogeneous response. But if you think at the level of the cell, there are just few ways a cell will respond for various stimuli. But that's a benefit to the field, that if you can find the dominant biologic mechanisms, we can interrogate them for management. And coming to the last trial that is ongoing, this is the COPE-AKI study. And here, coming back to the simple question, how can we help patients after they are discharged from AKI? So if you take common complications after AKI, these are over 1 to 3 years. I talked about premature mortality, cardiovascular, etc. But the thing that we all see, that is in the first year, the AKI patients come back with recurrent hospitalizations and rehospitalizations. It's about, the absolute risk is about 35%. For AKI-related hospitalization, about 30% for any hospitalization. So very high burden that you're going to see these patients in. And we asked the questions why this would happen. And several things came up. Few of these were lack of continuity of care, difficult time to go and see their primary care, the changes in pharmaceutical medications. We took like 10 patients who were discharged. They came in with about 10 to 12 medications. 5 of them were stopped. 2 were started, and the patient was given instructions on how to start others. And most of them get lost in this pharmaceutical management. And there is this gap in the first 90 to 100 days that the medication management is suboptimal and there are delays in follow-up care. But all this leads to increased risk of rehospitalization. So while we wait for the pharmaceutical companies to come with new drugs, we said, can we do a process of care interventions where a pragmatic trial, phase 3, again, a multi-center, our intervention is a nurse navigator. patients are randomly assigned to the intervention where if you are in this intervention arm, you get a nurse who will call you every week and ask you about your health. We also give them Bluetooth-enabled blood pressure devices as well as weighing scales. So we get changes in the blood pressure as well as weight. There's a pharmacist who will check on you to make sure that your medications are appropriately optimized for your GFR, which is still changing post-discharge. And if need be, you'll get a primary care or a nephrology visit. And the plan is to enroll around 2,000 patients over 2.5 years. About 7 sites are participating. And the primary outcome is the hospital-free days through day 90. So we are focusing on readmissions, because if we can reduce readmissions, we can possibly prevent AKI to CKD transition. And the study is over 18 months when it got started. The enrollment is slow, like in any clinical trial, but we have enrolled close to over 500 patients now across the sites. And this is the target, if we get attrition, if patients don't follow back, patients are coming back, they are engaging. So we are hoping the red line will reach the green line where we can get an answer to this question. So more to come in a year or two in this setting. But essentially, a great time to be in nephrology, especially doing research around AKI for various reasons. Several proteins are showing consistent findings in mouse and human tissue. They're tracking tubular health and disease for several months after episode of AKI. Urine biomarkers after hospitalization identify patients for kidney disease progression. Urine repair markers may assist with allocation and reducing organ discard. And we need to enhance the post-discharge care of our patients to prevent the long-term sequelae as well as burden to the hospitals. This is, I like this quote from Sir Wislam Osler, our clinical medicine father. A good physician treats the disease, a great physician treats the patient who has the disease. We need to identify pathways, biomarkers, prediction models that affect each and every patient and give them this targeted care. I have several people who participate in the studies, my team at Johns Hopkins, my collaborators, funding agencies, and several consortia. So as always, reach out with any questions, collaborations, sign up for nephrology, you won't be disappointed. So, thank you.
Let's start in the audience. I got to fix the mic. Let's start with questions here. And if you receive a question, could you repeat the question online until I get a chance to fix this mic? Go ahead. Anybody questions?
Yeah.
I'm going to ask you to use your crystal ball. Since we've been talking about biomarkers. Really got great talk. Biomarkers are very exciting.
Yeah, no, so come to the talk at 4 o'clock. I'll show you about 7 examples that are already in clinical practice. So the last 3 years have been good in terms of biomarker going through regulation and FDA processes. So once again, for the trainees in the field, there is research which tells you good evidence, but then each of the drug, biomarker, proteins have to go through this abyss where you have to go through the FDA approval, get the evidence, you have to get a good reimbursement rate, you have to get pharma companies excited so that they can do the marketing. Biomarkers fall into the space where, although kidney disease is common, it is not as common, where the business models are so attractive that the diagnostic companies will keep running after it. If you're developing a new BNP, you'll get everybody's attention. If you're developing a new marker of AKI and CKD, they look at you. But once again, the burden of evidence required to get them into clinical use is very high before they will take it on for themselves. But that said, urine NGAL now got approved 3 months ago. TNF-R1, R2, the kidney biomarker score is approved for early CKD. HFABP got approved in Canada and Japan. For phase 1 clinical studies, about 7 biomarkers got approved for nephrotoxicity. So the field is moving forward. I would love to see it move much faster like you do. I want to see few more things before I retire, but that's the reality. So it's not for lack of evidence. I would say it's all the way our healthcare system is situated. Unless you can make a good business case, the industry or your partners are not going to come in jumping to take this on.
Folks.
Oh, I didn't repeat the question.
So I had a question. The different tubules, like different biomarkers relate to different parts of the tubule. Have you found any patterns of injury? So for example, cardiorenal syndrome has a distinct pattern versus trauma bleeding out has a distinct, is there any patterns where certain biomarkers are more apparent so that you can make a faster diagnosis as the etiology of the ATN?
There are. So like in the setting of cardiorenal syndrome, there is a construct where you can use a set of biomarkers to say whether you have a functional cardiorenal syndrome or injured cardiorenal syndrome, or in the setting of cisplatin or nephrotoxic injury, you have a set of biomarkers that will help you differentiate it. The best example is acute interstitial nephritis, where the evidence is built significantly strong, where drug-induced nephrotoxicity can be picked up by the set of 3 biomarkers. I'll talk about it at 4 o'clock if you are there. There you'll see how the evidence progressed and where biology turned into a very good test that could be used. So once again, you have to go back and carefully do these studies and get it to the level that it becomes part of the guidelines. It's available for physicians to order it and change your management.
Just sort of one follow-up.
Yeah.
One follow-up. So will we be ordering a comprehensive panel in the future, and then we see because a lot of the time AIN, you unless you think it's a misdiagnosis.
No, so that was our dream, where when we did this unbiased proteomics, we said, can we send out a sample of urine, get a list of 100, 200 proteins which are there, and you get a report which is like, oh, 70% pretest probability of AIN and 30% of pre-renal, etc. And then based on the clinical condition. So the construct is there. Once again, we need technology to bring this available to each and every hospital where it can be run locally, or in a way that a sample can be sent and the answers are available, say the same day if you're on the service, or within the week if you are in your CKD patient. That's one thing, but those costs are coming down. Genetic tests used to be so expensive, and now you can do it very easily. That will happen with proteomics, hopefully. And the second is pricing it appropriately so it adds value to the healthcare system and not becomes a cost for sake of knowledge. Means that's important, but also you have to change Medicare. So it becomes a catch-22, but that would be ideal rather than biomarker for this disease and biomarker for that disease.
So it's a great talk. Thank you so much. So this is coming from a pulmonologist, so just be careful. And so we have a lung map. I'm very excited that there's some overlap. But one of the things that's become really apparent in the lung with normal versus abnormal repair, which is one of your important paradigms, is abnormal epithelium repairing. So are there phenotypes of tubular epithelium that you can track to normal versus abnormal repair?
So that's the kidney atlas one. So there is a whole section and proteins that will tell you the cell state, whether it's in that going towards maladaptive versus regenerative state. So that has been defined. And the Atlas 2 that is being written up right now, I'm calling it the Atlas because it has more pictures and more supplementary tables that you can ever use. That is becoming, it's highly validated. So that looks pretty good. So if you're working with a biopsy related information, you can rely on it.
And do these epithelial cells go down sort of developmental pathways when they're injured?
So some of them are, so the SOX2, SOX4, etc. was the last science paper that came out. They took data from KPMP also. There are development pathways. There are some phenotypes where we are seeing that.
And then just one last question, which I know you didn't show today, but since you have these precious samples, have you looked at the lipidome of these patients?
No, we have not.
Would you like to?
Yes, that would be great. So no. So if you are working on lipidomes, no, one of my thing is I'm ambassador to the KPMP studies. There is lots of sample that is available. There is ancillary study mechanism there. And if you have a setup to interrogate it, we would love to find it. So HFABP and LFABP were identified through the two biomarkers that are approved in Japan. They were identified through the lipidomic techniques, but not many people are working on it in the field. It may just be field specific. Yes.
Thank you, Dr. Parikh. I have a question. So the patients that you're advocating for that permissive hypercreatinemia,
Yeah.
at the time when they have the greater than expected rise in serum creatinine in response to renoprotective medication, they still have low levels of urinary biomarkers, correct?
Yes.
Do these subset of patients in the past, have they had a subclinical AKI, and that's why we're seeing like the creatinine just reach a steady state? Or is this just benign and reflective of creatinine as a whole?
It could be. No, this is a great question. It could be a combination of a lot of things. So a typical scenario is patient comes with 10, 15 pounds overweight, is having symptoms of shortness of breath. You diurese him and get 2 liters, 3 liters out. So suddenly your denominator of creatinine has gone away. The body is still equilibrating between the intracellular and extracellular compartments. And so you see the creatinine increase because of the thing. The patient is feeling better, but the steady state has not yet reached. If you wait for a few more days, all this creatinine comes back. So the thing that when I am rounding, if the patient is feeling better, I let it go. If I see the hematocrit getting more, I know that it's only the changes in the intravascular, which was because of my diuretics, and I feel very comfortable. So I've even written about this. So a change in creatinine with an increase in hemoglobin is a sign that it was diuretics and not injury. And if you're a renal fellow or other things, if you're a renal fellow and if you really doubt it, so we go and do a quick microscopy, and if you don't see any ATN CAS, I know that it is more of the equilibration. But these people actually come back down very beautifully. We all have a different rate at which our water compartment equilibrates. I'm going in a tangent here. So if you're in a dialysis unit, you remove 2 liters of fluid, 4 pounds from different people. Some people cramp, some don't. The people who are cramping are the people who are taking a longer time to re-equilibrate their water movement across the different compartments. It's the same phenomena you see when you use diuretics and get people volume depleted very fast.
Thank you.
Yeah.
And I know you had mentioned the marketability of therapeutics in kidney disease and also diagnostics. It would be, is it reasonable to understand, to propose that these injury repair mechanisms that we will target future in therapeutics is conserved across different tissues and not necessarily just the kidney, and therefore therapeutics will be directed against the same mechanism for different organ systems. Does that make sense?
It does make sense. And if you find such a drug that has pleiotropic effect, that would be amazing. Like so GLPs, they are showing pleiotropic effect. I know we see weight loss, but there is a lot more to it than weight loss. We are seeing cardiovascular benefit. We are seeing kidney benefit. The kidney doesn't have a lot of fat. Despite all of this, people are showing improvement with dementia, etc. So if you can target a pathway that can affect more than one organs, the clinical trials get much easier, much safer, and much better, because most of the time the endpoint is mortality. And usually it is mortality for a competing endpoint. But if you have like a statin-like drug or a GNP-like drug, it will go through the pathway very fast. So for example, the YKL-40, it is present in the chitin. Like if you step on a shell or a crustacean, that sound that is coming from the cell is the chitin. It's doing wonderful in the lung field where people are showing it could be a therapeutic marker and there are all these cell types. It's conserved very nicely in the kidney. So could there be a thing which is there? So people have written about this across organ, what is there, but I don't rule it out. It is a possibility.
In your research, have you found repair mechanisms that are similar in other organs, or that's not been a
We
collaboration?
see similarity. So like IL-18, which is a NF-kappa B and pro-inflammatory, it's present in different organs. There, YKL-40 is another example. IL-6 and MCP-1 are examples which are conserved, and it's the cry of many different organs. So it is there what you are saying. We are connected across organs and across species. How to modulate it, at what time and at what dose is the real wisdom.
Thank you. Wonderful talk. I have a very small question. The opioids that you're working with and the kidneys that you're looking at, are these AKI kidneys only, or
No, we
they're
are doing
all kidneys?
We're doing all.
Okay.
It's so although the research question is focused on AKI, when you are in the middle of the night and working with the opioid, we are taking all comers, and we are hoping we'll learn something across the spectrum of deceased donor kidneys.
And along the same lines, when is the urine collected from the donor? Is it in the OR at the time of procurement?
Just before the patient is wheeled to the OR. So right before that.
Very interesting. And the results, 20 minutes or so, you said?
15-20 minutes, yes.
Okay, great. Thank you.
Thank you.
Oh, we have time for one more.
And along those lines, for the same process, was there any potential utility in using that in biopsy deferment in patients that receive AKI kidneys that are making urine but may not have as progressive like resumption? So presuming that the donor wasn't able to receive that testing prior to going to the donation, say it's an OPO that's not participating, but would there be any use in using those same markers in a patient who may have progressive DGF after?
Yes, so that's the hope. So we have the same markers published in the setting of DGF. This is about 7-10 years ago. The literature and the answers are robust. The drug development was not as exciting in DGF it is today. So we pivoted and said in deceased donor setting, we can very quickly, without having a drug, change the outcome. But I do think, for example, YKL-40, we have published about it in JSON, it's 2017. We measured these markers around DGF. And if your patient with DGF had the marker, they recovered very nicely. So we have a 3-year follow-up on this. So I do think that the same markers can be used in the post-transplant setting. We just don't have a study ongoing right now.
All right, well, thank you so much. Appreciate you coming here, sharing your knowledge. Please help me welcoming Dr. Parikh.
Great questions. Yes.
I'll take care of
You can
it.
take
No
care of it.
worries.
I think, yeah, I just look at it.
Yes,
Fine.
let me just pause the recording.
This is Science, she's our chair of medicine.